Welcome, everyone. This is our first talk in the CyberPatient Expert Series. Today, I want to give you a short introduction. The CyberPatient Expert Series is an ongoing collection of webinars consisting of talks given by various medical professionals. And the goal of the series is for medical students and students in other medical-related fields, as well as faculty, to directly engage with accomplished physicians, to build connections, and to support the future of your medical education. So today we'll be welcoming Dr. Savvas Nicolaou. Dr. Savvas Nicolaou is the Director of Emergency and Trauma Imaging at Vancouver General Hospital in British Columbia, Vancouver, Canada, and a Professor of Radiology at the University of British Columbia. He completed his medical degree at the University of Toronto and his residency in Diagnostic Radiology in UBC. Dr. Nicolaou has consistently worked to improve equitable care for patients. Under his leadership, the radiology subspecialty care of VGH is now being provided to underserved and Indigenous communities within the Northern Health Authority and Interior Health Authority, along with improving the care for adult female patients at BC Women's Hospital. Additionally, Dr. Nicolaou has successfully worked to improve education. He's been actively involved in the teaching of medical students, residents, and fellows, and has served as the UBC Vice Chair of Undergraduate Education and Continuing Professional Development, and has been the recipient of multiple awards for teaching excellence. Finally, Dr. Nicolaou continues to be a major contributor in the field of emergency radiology. He has published over 180 articles and over 400 abstracts in peer-reviewed journals, with particular interest in ER trauma, musculoskeletal, and cardiac imaging. As a pioneer of the subspecialty of emergency trauma radiology, he's a world-renowned leader in the field and was recognized as a Canadian Fellow of the American Society of Emergency Radiology. So today, Dr. Nicolaou will be speaking on an approach to interpreting the abdominal radiograph and imaging the acute abdomen. So please, Dr. Nicolaou, take it away.
Yeah. James, thank you so much for that introduction, and very kind introduction. I'm truly honored and privileged to be here today and to be participating in this amazing CyberPatient Expert Series lecture series. Thank you so much, and thank you to everyone for joining us. Today's talk will be a practical approach to the imaging of the acute abdomen. And the objectives are, initially, I will go through a basic approach, how I interpret an abdominal radiograph. We'll go through some routine, basic radiographic and computer tomography anatomy. We'll go through an imaging approach to the acute abdomen. Throughout the talk, we will see some must-see acute abdominal cases that anyone that deals with the abdomen must be aware of these types of clinical scenarios. And through these cases, we'll illustrate the indications and limitations of plain radiography, ultrasound, and computer tomography. And then in the end, we'll finish with an imaging approach to the patient presenting with blunt and penetrating trauma. Now, to understand radiographs, we need to understand the positioning of the patient. And usually most positions for the abdomen are placed in a supine position with the film plate placed beneath their back and abdomen and pelvis. And basically this allows an even distribution of the anatomy and the abdominal organs, with the X-ray beam entering from an anterior to posterior projection. And that allows the best illustration of the soft tissues, the bony structures, and also the visceral structures from a plain abdomen perspective. However, this is just one view. The second view of the abdomen is an erect view, and this is important. We'll speak to why the erect view is important as well. And that is usually done with the patient in upright position. Again, the X-ray beam entering from an anterior to posterior perspective. The plate, again, the exposure plate is placed behind the patient's back and upper abdomen and upper aspect of the pelvis. And that's important also to identify the presence of intraperitoneal air, which is a very important sign to identify in the presence of abdominal pathology that we'll be talking throughout the talk. Now, they are interpreting the abdominal radiograph. We talked about how the radiograph is obtained, and that's critically important. One thing I would say for people that are dealing in the critical arenas, such as the intensive care unit or the emergency department, all x-rays are done in a portable fashion, and the portable machines that are utilized are limited in the amount of tube generation, tube current, and that limits how useful the x-ray can penetrate the human body and exposing the human body to be able to expose an image that is useful to interpretation. So you should always keep that in your mind, that when you're ordering x-rays, in the ICU, trauma bay, and also in the emergency department, that you are limited by the technique in being able to visualize appropriately the structures of interest. You can always order a radiograph within the main department if the patient's clinical status allows you to do so. Now, the three views that we usually do is a supine abdomen, upright abdomen, and also an upright chest radiograph. The chest radiograph is very useful in identifying intraperitoneal air, which is free air, inferior to the diaphragm, which is an important marker for bowel perforation. And this serves as an important marker to a very acute situation that the patient needs to be taken to the OR. It is also useful in identifying the presence of chest pathology that may simulate abdominal symptoms, particularly pneumonias within the lower lobes can simulate upper abdominal pain. Now, how do we know it's an upright abdominal film? Well, gas in the gastric fundus with an effluent level, the film must be taken in the upright position. It is useful for identifying bowel effluent levels. So effluent levels imply that air rises to the top, fluid settles at the bottom, and that's what we call an effluent level. As we can see in the gastric air bubble, and I'll show a couple of examples, we can see this is an upright radiograph. Given air rises to the top, fluid settles at the bottom, and there's a sharp interface between the air and the fluid and the soft tissue that is created given the difference in attenuation, meaning absorption, between air that doesn't really absorb the X-ray beam and soft tissue that absorbs it to some degree. And this allows us to identify that this is an upright radiograph. Useful also for identifying free air in the abdomen. And if we cannot obtain an upright abdominal radiograph, I think this is critically important, again, in the acute setting or in the ICU setting, or patients that, radiographs are taken when they're admitted to the hospital and they're sitting in different wards within the hospital. Basically, patients maybe cannot be put in an upright position or even in a sitting position. So you still want to identify the presence of free air. Then what we call a left lateral decubitus radiograph is also useful in the identifying the presence of free air, bowel effluent levels, meaning the following. A left lateral decubitus radiograph implies that the patient is lying on their left side down and right side up. So a left lateral decubitus radiograph implies left side down, right side up. If it was a right-sided decubitus radiograph, it would be right side down, left side up. And I'll show a couple of examples. So this particular radiograph, we know without any markers that have been placed that this has to be an upright radiograph because we can see the presence of a sharp interface between air rising to the top, fluid settling to the bottom, creating the sharp interface, the sharp horizontal interface between air and fluid, implying an airflow level. That's an airflow level. In this particular scenario, a very important marker. You see this beneath the right hemidiaphragm. This implies free air. There has to be a perforation to the bowel or to the duodenum, the two most common sites. Or this could be post-operative. If we saw this particular radiograph, this could be in keeping with a subphrenic abscess. And this is a left lateral decubitus radiograph. We can see the arrow pointing upwards. Left side is down, right side is up. And this is where the liver should be present. And we can see this free air that's insinuating along the free edge of the liver, implying the presence of a bowel perforation. Now, supine abdomen is useful for anatomy. And this is important for us to identify certain anatomical structures. So if we look at this particular radiograph, just click forward, let me just go back for a second. And we're going to go over the radiographic anatomy, but it's very useful. It's the best radiograph to see and confirm whether there are dilated loops of bowel. And we'll go through acute small bowel obstruction later on in the talk. Now, indications for abdominal radiographs, to be honest, the true indications is what I would say. If someone is looking for free air, that is a true indication. Bowel obstruction, true indication. A radiopaque foreign body post-surgery, counting sponges, counting retractors that could have been left within the human body. Those are proper indications for plain film radiographs. Realistically speaking, in this day and age, given that we have other types of imaging modalities, plain radiographs should not be performed for the cause and site of a bowel obstruction, abdominal aortic aneurysms, acute pancreatitis, acute appendicitis, ischemic colitis, diverticulitis, abscess, free fluid, renal colic. CT scan, realistically speaking, or ultrasound are the appropriate tests of choice in these particular clinical scenarios. Blunt abdominal trauma, do not get x-rays. That you're wasting time, and time is of the essence in the setting of acute trauma. You need to obtain a focused abdominal sonography for trauma that I'll speak to towards the end of the talk for the identification of presence of free fluid that indicates an injury to the abdominal visceral organs. And then a CT scan, which is the gold standard and the workhorse for abdominal trauma. Now, when we're evaluating an abdominal radiograph, I make it extremely simple. 3 systems: bowel gas pattern, soft tissues, the bones, and then 3 things to look for: free air, free fluid, and abnormal calcifications. And throughout the remainder of the talk, I'm going to be concentrating on these 3 systems, 3 things, and illustrating these with examples. So bowel gas pattern, soft tissues, bones, 3 things are extremely important: free air, free fluid, abnormal calcifications. There's another mnemonic to approaching an abdominal radiograph, what they call the free abdomen, that if you want to utilize from your perspective in looking at an abdominal radiograph. Free fluid, air, A stands for air, free air in the wall of the bowel or air in the lumen. B stands for bowel wall thickening, either dilatation and identifying whether it's large or small bowel. D for densities, bones, calcifications that could imply metastatic disease. And O for organs, looking at the kidneys, the gallbladder, the spleen, the pancreas, the urinary bladders, ureters, and the psoas shadows. So let's look at the anatomy from a plain radiographic perspective, and we'll illustrate this throughout the talk. We start in the right upper quadrant for, as I talked about before, we look at the soft tissues. We know the liver sits in the right upper quadrant, an important anatomical structure. We know the kidney sits immediately inferior to the liver, and this anatomic configuration, the hepatorenal recess or Morris's pouch, is an important anatomic space where the accumulation of free fluid first accumulates. So we've got the free edge of the liver, we got the right kidney in the right upper quadrant, we've got the right psoas muscle next to the right kidney. Move over to the left side now. We can see the left psoas muscle, we can see the left kidney, and situated in the left upper quadrant is the spleen, and more superiorly is the gastric air bubble that we can nicely identify. Those are important soft tissue structures. And then if we move towards the pelvis, we can actually see the bladder itself. And then we should be able to identify portions of the large and possibly the small bowel, cecum in the right lower quadrant, ascending colon, transverse colon, descending colon, sigmoid, and here we see the sigmoid and part of the rectum. It usually has air and fecal material within it. And that implies the large bowel as a picture frame in the peripheral aspect of the abdomen. Centrally, when we see areas of gas, that implies the presence of small bowel. And we'll go through some features between large and small bowel later in the talk. Other important structures, of course, identifying the skeletal elements. Of course, the spinous processes, the stout-like processes projecting from the spine. These owl-like processes are the pedicles. These are important anatomical landmarks that you have to identify within the bones. Sacroiliac joints, the sacral arcuate foramina, of course, the hip joints, the acetabulum, the femoral heads. And then we identify the inferior and superior pubic rami, the symphysis pubis as well. And these are important anatomical landmarks that you should be looking at on every single abdominal radiograph. I'm just going to review briefly the anatomy here, and then we'll come back to the anatomy towards the end of the talk as we talk about trauma and why it's critically important to understand the anatomy. One thing I would say about radiology and imaging, knowing your anatomy is critical to understanding imaging and understanding pathology. And I'll illustrate those principles throughout the talk. What we have on the left is a plain film of the abdomen. What you have on your right is a reformated volume rent image of the soft tissue structures that is taken from a CT scan to illustrate some of these principles that we talked about. So plain film of the abdomen, we've got a CT image on your right-hand side illustrating the liver in the right upper quadrant. Now, if we go further posteriorly within the abdomen, we can see the liver in the right upper quadrant. We can see the right kidney that's placed next to the liver that I talked about, the right psoas muscle, moving to the left side, the left psoas muscle, left kidney, left spleen, and of course, some of the bony anatomy. If we inject a special type of material that I'll talk about, named contrast material, into your vein that opacifies your venous and arterial structures, we can identify the kidneys that light up with contrast. We've got the abdominal aorta and the IVC as well. Important vascular structures as well that we can see within a CT scan, but we cannot really identify on a plain film of the abdomen. We could identify it on the radiographs, but there we'll have to inject the contrast and then expose the radiograph to identify those vascular structures. Now, other anatomy, this is a coronal view of the abdomen on a CT scan, and we can see the liver in the top right upper quadrant. We can see the hemidiaphragm, the right hemidiaphragm, left hemidiaphragm, important structures. So when we see air insinuating inferior to the right hemidiaphragm, it shouldn't really exist there. So we know that implies free air, intraperitoneal air, indicative of a bowel perforation. We can see the lower aspects of the lungs that insinuate over the right hemidiaphragm, liver, spleen, and gastric air bubble as well. We see the right left kidney, right and left psoas muscle. We see the sacroiliac joints and the right ilium, alar portion of the sacrum, important anatomic landmarks that we correlate back to the plain radiograph. To understand anatomy, you need to move from one imaging modality to the next to properly understand the anatomy on the plain radiograph, given it's difficult to visualize these structures. By knowing your CT anatomy, you can take advantage of that anatomy and transpose it to the plain radiograph. Now, one thing I would say about a CT scan, of course, it's a very useful imaging modality because you're able to identify different structures that we talked about, because it's like a loaf of bread. And on a CT scan, instead of looking at the whole loaf, we're looking at individual slices of that loaf, and we're looking at the grain and texture of each individual loaf. And given that anatomical structures absorb the X-ray beam to different degrees, we're able to also quantify the degree of absorption, and that helps us identify different types of anatomical organs, anatomical structures, but also anatomical pathology. For example, air is -1,000. It's extremely dark, as we can see here with the colon. We know that fat is -100 Hounsfield units, which is part of the retroperitoneum and part of the subcutaneous fat. Water is 0. Blood is usually around 30 to 40 Hounsfield units. The bone can range anywhere between 500 to 1,000, and usually plus 1,000 is usually metal, is what I would say. So these are important things to understand in the back of your mind when you expose the human body to an X-ray beam. They will absorb, attenuate, and display different characteristics based on that basic principle of the differential absorption of that X-ray beam. They will be displayed differently based on that attenuation. So it's important to understand air, extremely dark, doesn't attenuate the X-ray beam. Bones and metal absorb it to a significant degree. They appear extremely bright. And of course, the other thing that's on the CT scan that we're seeing is that kidneys are lighting up as bright. So is the aorta, because we injected a specialized iodinated contrast material that lights up the organs. Now, some important anatomical aspects that I'll talk about. Everybody knows about cadaveric specimens, and there's a slice through the L1 anatomic region, a very important anatomic region. And we can see anatomical structures I'll review later on towards the end of the talk again, nicer on a CT scan. But what I want to emphasize is we don't look at cadavers in a clinical scenario. What we're looking at is CT scans, X-rays, ultrasounds, and MRIs. So we have to understand our anatomy based on a CT scan level, where we see the liver, the pancreas, the kidney, the spleen, part of the large bowel, the stomach, the aorta, and the IVC. So it's important to understand these anatomical landmarks from a cadaver that you do in anatomy, transpose that to a CT scan, because what you're seeing in real life every day is not a cadaver that is taught in anatomy labs. It's actually CT scan and plain X-ray and ultrasound anatomy that matters in a clinical environment that you must become familiar with. And this is another coronal image of the liver in the right upper quadrant, the kidney, the psoas muscle, kidney, spleen, stomach, nicely illustrated on a CT scan. The liver, spleen, psoas, kidney, and the spleen. Sorry, that's right kidney, left kidney, and the spleen in the left upper quadrant. So, history. Patient presents with vomiting, nausea, and obstipation. That means the lack of passage of gas. What would be the initial imaging modality? A plain radiograph is a good imaging modality when you're thinking about an acute small bowel obstruction. And what we can see in this particular scenario, we can see numerous dilated loops of small bowel present centrally within the abdomen, and that is pathognomonic of an acute small bowel obstruction. There's a CT scan that shows numerous dilated loops of bowel filled with fluid centrally within the abdomen. Another, on the CT scan, another important anatomical feature, markedly dilated loop of small bowel. We'll talk about how we can identify that it's small versus large bowel. Now, how do we tell between small and large bowel? I'll re-emphasize these principles. Small bowel sits within the center of the abdomen. It has the valvular conventes, the mucosal folds of the small bowel, and I illustrate that again with another example, run across the whole circumference of the bowel, where the large bowel is at the peripheral aspect of the abdomen, and it has hausdry, or the mucosal folds, and these are interrupted. They don't course along the whole circumference of the bowel. Now, gas pattern, assess the diameters of the various bowel segments for bowel dilatation, and abnormal dilatation in any segment of the bowel is suggestive, maybe paralysis of the bowel, a mechanical obstruction. It could be a volvulus, meaning a closed obstruction, ischemia, meaning lack of blood supply to the bowel. And those are important determinants. Now, the gas pattern, mucosal folds that we talked about, if they're uninterrupted, or the valvular conventes of the small bowel. If they're interrupted, they're the hausdra of the large bowel. Location, small bowel central, large bowel peripheral. Maximum diameter of a small bowel, 3 centimeters, large bowel, 9 centimeters the cecum, or 10 centimeters or above. Transverse colon, 6 centimeters. Maximum fold thickness, 3 millimeters for small bowel, 5 millimeters for the large bowel. Other rarely contains solid fecal material in the small bowel. If you see solid fecal material in the small bowel, known as the small bowel feces sign, there's an important sign that you're dealing with an acute small bowel obstruction. The large bowel commonly contains solid fecal material. So this particular example, we can see the valvular conventes, these mucosal folds are running across the whole circumference of the small bowel. They're centrally located, they're dilated more than 3 centimeters. That is pathognomonic of an acute small bowel obstruction. Now, what is different in this particular radiograph? Now, we know this is an upright radiograph, correct? Again, valvular conventes, these bright soft tissue structures of the valvular conventes coursing along the whole circumference of the small bowel. We can see the sharp interface that I talked at the beginning of the talk, where you see air rising to the top, fluid settling at the bottom, that creates this sharp interface, given this sharp differential absorption of the X-ray beam between air, soft tissue, and fluid. That creates a sharp interface known as an air fluid level. That is very important that we're dealing with an upright radiograph. In the setting of a bowel obstruction, we're dealing with an acute small bowel obstruction. So, rules of 3, very simple. I like to make things simple. 3 loops of bowel with a diameter dilatation of 3 centimeters or more, with a mucosal or bowel wall thickening of 3 millimeters or more, or 3 or more bowel effluent levels implies a small bowel obstruction. Again, rules of 3. 3 loops of bowel dilated more than 3 centimeters, 3 millimeters or more thickened mucosal folds of bowel wall, and 3 or more small bowel effluent levels implies an acute small bowel obstruction. These are pathognomonic features of a small bowel obstruction, something that everyone needs to identify if you're interpreting an abdominal radiograph. Remember, the most common cause of small bowel obstruction in the developed world is adhesions. There are other causes such as inflammatory bowel disease, hernias, and malignancies. They could be partial or complete. They could be simple or strangulated. Now, what do I mean by strangulated? That means compromise of the blood supply to the bowel, which is a very important determinant that you need to identify because it means that person needs to go to the OR to relieve that bowel obstruction, or you'll end up with dead bowel. Let's look at another case. 75-year-old male presents with sudden onset of vomiting, abdominal pain with lack of passage of gas. What would be the initial imaging modality? So again, if we look at this particular scenario, these are a pathognomonic case. We see an abnormally dilated loop of bowel sitting in the right aspect of the abdomen, but also in the right lower quadrant. This is a pathognomonic feature. That's why I'm showing this case. And this case implies a sigmoid volvulus. Now, there's some pathognomonic features. Sigmoid volvulus sits in the right lower quadrant. If we had an abnormally dilated loop structure sitting in the left upper quadrant, that would imply a cecal volvulus. What do we mean by a sigmoid volvulus? We know there's a mesentery, the blood supply, that sits in the mesentery of the sigmoid, and the sigmoid can twist on itself, as we can see in the schematic depiction. And if the sigmoid twists on itself or any other loop of bowel, we call that a volvulus. And that implies interruption of the blood supply to the bowel, and that is a critical surgical emergency that needs to be at least relieved, or you will end up with a dead sigmoid or dead bowel. And the pathognomonic features are this inverted U-shaped loop of bowel, but also in the center of the bowel, we see this soft tissue structure, which are the two walls of the sigmoid that come together and oppose each other, given the sigmoid is twisted on itself, and it creates what is called the coffee bean sign, indicating opposed walls of the twisted sigmoid colon. And this is pathognomonic feature of a sigmoid volvulus, a must-see case, a must-see identification when you interpret a bowel radiogram. Now, large bowel obstructions, you can have colonic cancer, diverticular disease, inflammatory bowel disease, tuberculosis, a sigmoid volvulus. You can have extrinsic compression, hernias, and a paralytic ileus, meaning an Ogilvie syndrome that could be from post-operative or a metabolic cause from an electrolyte imbalance. Next step. Usually, at our institution, we'll do a high pH enema, we'll introduce this water-soluble contrast material through the rectum, and you can see it being opacified under the radiograph. And then what it creates, we can see this sharp transition where the contrast is not flowing freely to the remainder of the bowel. And that beaked appearance is pathognomonic. This is a lateral view. It's pathognomonic of a sigmoid volvulus. The reason why we try these high pH enemas, because this could relieve the sigmoid volvulus. Now, when do we use water-soluble enemas? Indications: intestinal perforations, intestinal obstructions, esophageal leak, and anastomosis leaks as well. And it's water-soluble material. It can be very useful. In our case, we do a high pH enema. If it's relieved, then you move on. If it's not, then we might need to do a CT scan to further define what the etiology of the sigmoid volvulus might be. And then if it's not relieved, then on to surgery to relieve that obstruction because we've compromised the blood supply. Next case, patient presents with acute abdominal distension, tympanic to percussion, bowel sounds are present, blood work is normal, weight loss. What would be the initial imaging modality? We can see there's an abnormally dilated structure in the left upper quadrant. This could be a cecal volvulus, or it could be a routine large bowel obstruction. We can see from the contrast material that's been administered within the abdomen, we can see the large bowel is dilated. It's the large bowel, it's peripherally located within the abdomen. There are haustra that are not circumventing the whole circumference of the large bowel. And then this is the money shot where we look at the bottom within the pelvis. There's a CAT scan. This is anterior, posterior, right and left of the patient. And we can see in the pelvis, there's an apocore lesion, soft tissue mass that's encircling the distal rectosigmoid portion of the large bowel, implying a large bowel carcinoma. And we can do a high-pake enema as well in this particular case, and we do those, and that indicates an obstructive colonic cancer. There's a polypoid mass protruding into the lumen of the cancer, and there's plaque-like elevated growth from the mucosal surface, what we call an apicore lesion, where the tumor is growing. As you bite into an apple, you create this apicore lesion, and that is a pathognomonic feature of an adenocarcinoma of the large bowel. Now, what is contrast? I've talked a lot about contrast. Basically, contrast is opaque to the naked eye, and this is what it looks like. They come in these bottles. It's water-soluble material. Usually, it's what we utilize in the radiological field, and we can introduce contrast, as I've shown, either through the mouth to opacify the esophagus, or we can introduce it through the rectum, or we can introduce it through the veins. And why is contrast so important? Because in contrast, we have a compound known as iodine. Now, iodine is a very useful element that is utilized in the imaging field. And the reason for that is it has a high atomic weight number of 53, the atomic weight number of iodine. And given this high atomic weight number, iodine has special magical properties that when you expose a radiograph or an X-ray beam with iodine present in the body that is introduced through these various ways that I've described, it lights up when you expose it with an X-ray beam. So it has these unique spectral magical properties that it lights up. So that can opacify organs, it can opacify vascular structures, it can opacify the lumen of a bowel. So it's a magical substance that is utilized in the world of imaging. Now, contrast media are introduced to the body to help visualize the structures being examined. One thing I want to say, though, for anyone that's practicing in the field of medicine, if you're going to order a contrast study, provide a GFR, a glomerular filtration rate, because it's important for us to understand what's happening with the kidneys, as these contrast materials could be toxic to the renal tubules. Only if you have people that have type 2 diabetes, if you're on metformin, you need to hold the medication. People with because you can induce lactic acidosis, particularly if your renal function is compromised. So we need to understand what the renal function is before we inject these types of materials, not for the bowel and the esophagus, but only if we introduce these materials intravenous. Now, risk factors is anyone with drugs that could cause toxicity to the kidney, multiple myeloma, dehydration. Intravenous agents can cause allergic reactions, but even if somebody has an allergic reaction, we can give epinephrine, but we also can pre-medicate them with prednisone and Benadryl to prevent an allergic reaction. So always remember to assess the renal function, but also remember we also use a specialized contrast with MRI examinations called gadolinium that can cause nephrogenic systemic fibrosis, which is a fatal condition. So you need to assess the kidney function before you inject these types of contrast material. Now, one thing about an eyeless, I talked briefly about an eyeless. You'll see that a lot of people that are doing clinical rotations presently, you'll see abnormally dilated loops of bowel, usually nausea, vomiting, abdominal pain. Usually the etiology is post-op, can be trauma, ischemia, peritonitis, anticholinergic drugs. Radiological findings, usually you see air within the large bowel and small bowel. And you can't demonstrate an obstruction on a CT scan. So usually just remember paralytic eyeless, very common in the post-op environment. Another case, patient presents with severe central abdominal pain on examination. Generalized tenderness was noted with peritoneal irritation. What would be the initial imaging modality? Upright chest radiograph, and we can see free air inferior to both hemidiaphragms. So an important and a distinction to make when you're looking at the radiograph, an upright radiograph, am I dealing with free air? In this particular scenario, in this particular patient, is a supine radiograph because you can see the arrow pointing downwards. The patient had a tube placed within the biliary tract, and we can see there's numerous dilated loops of bowel as well. That can happen. When you do an ERCP and you put a biliary drain, you can induce pancreatitis or you can perforate the lumen of the bowel. as happened in this particular scenario. And we can see numerous dilated loops of bowel. But one important thing that I want to bring out to your attention on the supine radiograph, you can identify intraperitoneal air. And the way to do that is what's known as Wriggler's sign. Basically, if you have air within the lumen of the bowel and air within the abdomen, you're able to identify the wall of the bowel because you have air within and without. And that allows you to identify the air of the bowel, as I'm showing you in this particular illustration, a beautiful illustration, where we see the wall, this high-density structure that I'm outlining with my mouse. This is the wall of the small bowel that I'm able to delineate. If you're able to delineate the wall of the bowel, be very concerned that there's air within the lumen of the bowel, but also air outside the lumen of the bowel, indicating the presence of intraperitoneal air, a very useful sign in identifying free air on the supine film of the abdomen. Now, if you can get an upright radiograph, you can do what we call a left lateral decubitus radiograph, left side of the body down, right side up, and then we can see air rising to the top riding over the surface of the liver, indicating the presence of free air. And these are CT scans, anterior, posterior, right, and left, and we can see free air rising to the top. Free air always rises to the most non-dependent portion of the abdomen, which is in the anterior aspect of the abdomen when you're in a supine position. Now, free air is not normally found outside the bowel. The presence of air outside the bowel implies intraperitoneal air, could be retroperitoneal air, could be branching air within the liver, portal venous gas, which implies ischemia, could also be gas within the biliary tree that implies pneumobilia, could be an abscess that I showed the first example, a subphrenic abscess, or if it's within the bowel wall, that implies pneumatosis intestinalis, can be ischemia or can be benign as well. Now, intraperitoneal air, the most important thing that I want to emphasize today, if you see that, as I've illustrated, it is a surgical emergency. So what are the two main causes? Bowel perforation or duodenal ulcer perforation. And then also following laparotomy or laparoscopy, you can see free air. Don't be faked. If you do see it post-surgery, usually this will resolve with 1 to 2 weeks. Now, free air, a perforated bowel is a medical emergency requiring urgent surgery. Bowel contents can enter the sterile peritoneal cavity and can cause an infection, an abscess, and can cause sepsis. So that is important. That is a surgical emergency in the acute setting. You must be able to identify this on the abdominal radiograph and notify the surgeon that you're dealing with a surgical emergency. What about this case? Patient presents with jaundice, distended abdomen, cirrhosis. Now moving to being able to identify free fluid. Very difficult to identify free fluid in the abdomen, but if you see this sort of ground glass, this sort of glassy appearance to the abdomen, you're dealing with free fluid. One thing I would say, I don't want to waste too much time on free fluid within the abdomen, because if you worry about free fluid within the abdomen, get an ultrasound. That is the test of choice. But if you see this sort of hazy appearance to the abdomen that I'm showing right now, you might be dealing with free fluid or cirrhosis. A patient might have cirrhosis, you have ascites, get an ultrasound, as I would say. Free fluid is better assessed with ultrasound, given it can detect 0.5 cc's of fluid within the abdomen. On a CT scan, again, the patient in supine position, anterior, posterior, right and left. Anterior, posterior, right and left. We can see free fluid within the abdomen. That implies many different types of pathologies, but at least you've identified the cause of the ascites. Could it be cirrhosis? Could it be a low protein state? Could it be metastatic liver disease? Could it be cardiac failure? Could it be renal failure? Could it be peritonitis? Could it be a malignancy? There's a lot of other causes, renal, pancreatic, vascular, uterus, gallstones, bladder, pediculate, and dermoids as well. Now, let's look at calcifications. In this particular scenario, we can see there is an abnormally dilated calcified structure in the right upper quadrant that's sitting below the liver. That is a calcified gallbladder, known as a porcelain gallbladder. Important to identify this on the abdominal radiograph. Given a porcelain gallbladder has an increased incidence of malignancy, it needs to be removed. Now, calcifications can imply many things. I want to show this particular case is a real case from my institution. Left lower quadrant pain is the history, query diverticulitis, WBCs of 18, elevated white blood cell count. So this is the reason why I say you have to have this approach to the abdominal radiograph. We talked about the three systems, the soft tissues, the valves, the organs. We talked about the three things: free fluid, calcifications, and the bones. Calcifications, why is it important? Remembering this was a case done for diverticulitis. We can see in this particular radiograph, we can see a curvilinear aspect. I've magnified it, that is present within the abdomen. Now, what is that curvilinear structure? Further magnified view reveals that this is a curvilinear structure that is calcified within the abdomen. If you see a curvilinear structure that is calcified in the abdomen, it is an abdominal aortic aneurysm until proven otherwise. And that's what, in this case, this was. Very subtle finding. But if you identify this, as I did in this particular case, immediately I went on to a CT scan, which is the next appropriate imaging modality. And on the CT scan, what we can see here, the contrast is opacifying a dilated abdominal aorta, which is an abdominal aortic aneurysm on a coronal and axial view. And we can see this, a lot of soft tissue or fluid that is surrounding the aorta, indicative of a ruptured aortic aneurysm, which is a surgical emergency. So that is, again, comes down to that skill set that I talked about at the beginning. Understanding the calcification implies an aneurysm. You can get the appropriate test, which is a CAT scan that shows the appropriate pathology, which is a ruptured aortic aneurysm. So again, the calcification, the first clue that you're dealing with a calcified aortic aneurysm that is ruptured in this particular scenario. 72-year-old male diagnosed with prostatic cancer presents with leg pain and back pain. And we can see now we're looking at the bones. It's the last structure we look within the abdomen. We can see its increased density throughout the skeletal elements, very dense. You can see it within the sacroiliac joints, within the superinferior pubic rami, within the skeleton itself. Then that implies diffuse metastatic disease. So it's important to look at the bones. We can see on the CT scan, on the coronal view of the CT scan, we can see diffuse increased density, implying metastatic deposits. So very important. And these are osteoblastic. In this particular case, it was prostatic osteoblastic metastasis. This patient presents with symptoms of anemia and upper abdominal pain. We've also got to look at the soft tissue structures, and we can see in this particular scenario in the left upper quadrant what normally exists. We know there's the left psoas muscle, the kidney, and the spleen. We can see this, the spleen is enlarged in this particular scenario in a patient with anemia. This is splenomegaly. So you've got to also look at the soft tissue structures, look at the visceral organs, because you're able to make significant diagnosis from the plain radiograph. The spleen sits in the left upper quadrant, becomes extremely enlarged, displaces the gastric air bubble immediately, also obscures the left psoas muscle and also the left kidney as well. Splenomegaly. So let's put all of these things together. So we're coming down to the end of the talk. In the next 5 minutes, I'll sort of put a couple of scenarios together and we'll finish off with trauma towards the end of the talk. And then I can stay a little bit extra for questions. 70-year-old female presents to the ED with acute lower quadrant pain. So we know McBurney's point sits in the right lower quadrant, 2/3 from the umbilicus to the anterior superior iliac spine. McBurney's point is where the appendix is. So 70-year-old female presents to the ED with acute lower quadrant pain. We can see that the parameters are all implying that it could be appendicitis, but it could be something else. So we need to understand in a 70-year-old female that there could be other pathologies that could be present in the acute right lower quadrant. What would be the initial, which one of the following imaging modalities would you initially use? So because it's a 17-year-old female, you want to limit the radiation. So you want to use MRI or abdominal pelvic ultrasound. If required, you could use an abdominal CT, but that would expose the patient to radiation. What you don't want to use is an abdominal radiograph. That's the study not to perform. And then you have numerous pathologies. So it could be inflammatory bowel disease, infectious uveitis, small bowel obstruction. It could be appendicitis, diverticulitis. You also have to think about the genitourinary etiologies, such as pelvic inflammatory disease, ectopic pregnancies, ovarian torsions, which are very important etiologies when you're dealing with pain in a 17-year-old female. We have the American College of Radiology appropriateness criteria, and you can refer this yourself. I just bring it to your attention, and those give you a rating of what is appropriate and not appropriate for a particular clinical scenario. Remembering appendicitis, you can perform ultrasound, and there are pathognomonic features of appendicitis within on ultrasound and CT and MRI. I'm not going to go through these. These are we will post these talks for your perusal so you can have it for your own understanding. But basically, if you see a blind ending structure that is non-compressible, that is pathognomonic features of acute appendicitis. On a CT scan, on a coronal image, we can see the appendix lies in the right lower quadrant. It's distended, it's inflamed, there are calcifications that are present. Those are pathognomonic features of acute appendicitis. Now, pelvic inflammatory disease also needs to be considered, like tubo-ovarian abscess. Ectopic pregnancies are very important in a woman of childbearing age. And of course, ectopic pregnancy is a surgical emergency. Other common right lower quadrant pain, endometriosis, ovarian torsions, which there's lack of blood supply to the ovary, are other important etiologies you need to consider in the setting of a young female presenting with acute lower quadrant pain. So you understand, you have to bring everything together that I've talked about, understanding the different powers of each imaging modality. So I'll finish off in the last 5 minutes with imaging in trauma and introduction. Now, remembering that trauma is the most common cause of death in patients under the age of 45. It is a huge financial burden to our society, with trauma costs exceeding over $300 billion in 2008. Now, which test is the test of choice in trauma? It is a CAT scan. Computerized tomography is the test of choice in the setting of trauma. CT scan improves mobility, mortality in polytrauma patients, remembering that a lot of the patients that present in an acute trauma situation, their abdominal exam is normal. Also, they could have a decreased GCS, the Glasgow Coma Scale, that limits the neurological exam from a clinical perspective. Remembering an ER trauma team is a team-based approach. You need paramedics, nurses, emergency physicians, trauma surgeons, CT technologists, and emergency trauma radiologists, such as myself. The golden hour, what I would say, the first 60 minutes is matters the most in whatever you decide to do that's going to impact the mobility and mortality of a patient. Now, usually the primary survey that everyone's talked about is airway, breathing, circulation. What I would challenge is that C stands for CT, because a CAT scan can better identify the source of bleeding. At our institution, we have a trauma bay. Our CAT scan sits next to the trauma bay, because it's critical to get to these patients to the CAT scan to be able to image them and identify the source of bleeding. Now, I'm just going to show you a scenario. I'm just going to stop this. I'm just going to show you a scenario of how quickly it is to scan a trauma patient. And this is how quickly it happens in a real-life situation. So we're going to scan from the top of the patient, from the head all the way down to the pelvis. And this patient has significant injuries, disruption of the diaphragm, herniation of bowel into the pericardial sac, but they also have disruption of the pelvic arterial vasculature, and the patient's actively bleeding. So let me just play this clip, and we can see we're scanning from the top, we're going through the chest, all the way through the heart, the abdomen, the pelvis, in a matter of seconds. In a matter of 6 seconds, a complex pelvic fracture. So we can see the diaphragm is disrupted. Because we know the diaphragm is disrupted, the fibrous pericardium attaches to the pericardial sac. We can see the diaphragm should be continuous. It's disrupted centrally. We can see loops of bowel that should not be present within the pericardial sac, impeding appropriate filling of the cardiac chambers. The patient was transferred to the interventional radiological suite. We can see a traumatic pseudoaneurysm from the pelvic arterial vasculature. It was successfully coiled and embolized, and we stopped the bleeding, and we saved the patient's life. Now, we can also perform CT imaging with penetrating trauma. This unfortunate patient had a penetrating object to the right lower quadrant. With a CAT scan, we can slice through these anatomical layers, and we can identify where these penetrating structures are actually present. It's very important to a surgeon. This actually penetrated the bowel and impaled the right ilium of the right iliac crest. But nicely, we can illustrate the abdominal aorta, common iliac arteries, that is not traversing the vascular structure. But still, it has gone through the large bowel and is impaling the right iliac crest. And we can see on a sagittal image as it is coursing through the large bowel and impaling the right iliac crest. This was successfully taken out. But the CT scan also provides a good roadmap to the surgeon. Now, the role of the FAST is to examine in the right upper quadrant, left upper quadrant, the pelvis, and pericardial sac for free fluid. And that is the test of choice initially as a screening tool in the setting of trauma. And predictable locations of fluid are in Morrison's pouch, pericardium, in the pelvis, and also the splenorenal recess. And what I'm showing is a pathognomonic feature. What the red sort of depiction is depicting is fluid that is present in Morrison's pouch. Now, CT scan anatomy, which is very important, and just for time, don't have to clearly emphasize, but on a CT scan, you have to know your anatomy. We talked about the liver, we talked about the IVC, the abdominal aorta, the abdominal muscles, the pancreas, we talked about the adrenal glands, the kidneys, the spleen, the stomach, the bowel. Important structures to identify, and I'll show you why. Coronal image, the same, the abdominal muscles, the IVC, the aorta, the liver, the diaphragm, the kidneys, the large bowel, the psoas muscles. And also, again, the coronal image, the liver, the spleen, the diaphragm, on the left, the right, the kidneys as well. Remembering nice rhombiform shape to the right kidney and the left kidney. Why is this important? These are the last two examples. 26-year-old female involved in a motor vehicle collision. We can see a normal anatomic depiction of a left kidney. Anterior, posterior, right and left, the spine at the back. So we know this is the left kidney, normal anatomic configuration. We don't see a right kidney. Why? Because it is completely fractured. It is completely shattered. We don't see a proper right kidney. And that is a surgical emergency. Why is that? Because the kidney is shattered. We have a hepatic laceration, but we also have this lucency that I talked about is gas that is outside the lumen of the large bowel, indicating a bowel perforation. The patient must be transferred to the OR. The patient was transferred to the OR, and the kidney was removed. This is the kidney from the real case that I've just shown you, a shattered kidney, completely fractured and shattered with active bleeding that was taken out of the OR, and the patient's life was saved. Another example of penetrating injury to the back with a penetrating stabbing. Again, we could utilize CT imaging that goes from the back to the front, and we can see that this does not traverse any vital structures, is what I would say. It sort of touches along the left kidney, but does not impale the abdominal aorta, which is a very important structure, is what I would say. So that was very important to the surgeon. So it went through the inferior surface of the kidney. Then if we look at the CAT scans that were done, anterior, posterior, right and left. Sorry, let me go back here. Right and left, anterior, posterior, right and left. We can see there's an injury to the right kidney. It's a little bit of contrast material indicating active bleeding. We can use color-coded images, and we can identify this area of bleeding, which I'll show you very quickly here. Just lay this plate right here. We can see this orange material is contrast leaking right here, leaking from the right kidney. So right there, right kidney, liver, left kidney. You can see this bright orange material leaking from the right kidney, indicating active contrast material that is leaking, indicating an active bleed. The patient was hypotensive, tachycardic. The patient was transferred to the interventional radiological suite, where we can perform under radiographic guidance, under fluoroscopic guidance. We can identify the site of bleeding in the right upper quadrant, and we can successfully put coils and catheters into selectively embolizing the kidney, stopping the bleeding, saving the patient's life. So, in essence, real lives, real people, real decisions, real anatomy. not the learning channel, not the history channel, not the A&E channel. Learn your CT anatomy. You will save lives. Have an approach, as I talked about, to the abdominal radiograph. Understand the different power of the different imaging modalities within the abdomen. And if you understand these basic principles, you will save lives. Thank you for your attention. It's been a pleasure lecturing to you today. Thank you so much.
Incredible. Thank you for that talk, Dr. Savvas Nicolaou. Great to see the how much you can learn by actually visualizing the real cases and how these patients and the decision making that went into which image modality to use. I would just like to bring up to the participants, please keep asking your questions. The Q&A is open. And I will start off with one of the first questions here. So based on, this is a question regarding decision making within that first 60 minutes. So physical exams are clearly not proficient with only, I think it was mentioned 20% in identifying.
Yes.
So here the question is, what are the risks in making the decision to use each imaging modality? So do some imaging modalities take more time despite having a better chance of making a diagnosis? And how is this decision making made, and how does this triaging work?
Sure. And it's an excellent question. And as I mentioned at the beginning, usually in a trauma situation, it's always an assessment of airway, breathing, circulation. The issue, though, in a trauma situation, airway is easy. You can intubate a patient. You can put a stethoscope on the chest to ascertain, appropriate auscultation, and you can have a special CO2 monitor to see you're emitting CO2, that you've intubated the patient appropriately. However, the source of bleeding, which is the most common cause of death in the setting of trauma, is extremely impossible at times to determine from a physical exam. The parameters that I talked about, the blood pressure, the patient's heart rate, respiratory rate, also measuring the acid-base deficits, are not useful indicators in the setting of trauma, particularly in young individuals. Thus, you have to make a decision that what is really the best test? What is really the best test in a limited amount of time that's going to give you the best result in giving you that roadmap to the critical injuries that you can make a quick decision to save that patient's life. And realistically speaking, if you have access to a CAT scan machine, the decision is very simply made, and I will make it today. It is a CT scan that needs to be done urgently without any wasting of time in performing x-rays that a lot of people try to perform in the setting of trauma. You could do an ultrasound, and the ultrasound could actually be done by a paramedic or any individual, to be honest, that could be guided nowadays with those images being relayed to a specialist like myself and guiding and interpreting those images initially as the patient's being transferred within a helicopter or an ambulance. They could do a portable ultrasound, a point-of-care ultrasound, given that you could do an ultrasound on your iPhone nowadays. And those images could be relayed. The problem with ultrasound that I would say is a big problem, it is operator dependent. It is very dependent on the clinical expertise of the individual performing the ultrasound. And unfortunately, if you don't have a lot of experience, you could make fatal errors. But at least if you have access to it, you could try to perform it, because if you see free fluid, you could bypass a CT scanner and go straight to the OR, because free fluid in the setting of blunt trauma implies there's a rupture of an organ or a rupture of a vessel that implies active bleeding within the abdomen. But the test of choice in a clinical scenario is a CAT scan. It is a lifesaver. It is the test that has revitalized and revamped and reimagined the care of a trauma patient in the acute setting.
That's great. And that leads to the next question here by Maria, and it's based on what situations can we actually perform CAT scans? Does the patient have to be vitally stable?
No, it's interesting. It's a great question. In our institution, that's why I showed the image where our CAT scanner is next to the trauma bay. And I would say if anyone was designing an ED department or designing the placement of a CAT scanner, the closer, or in some institutions place them right in the ED, the closer it is to the patient, the better it is. Because at that moment in time, it opens up the possibilities of what Maria has alluded to, that the patient usually should be stable. But however, if your CAT scanner is very close to your emergency department or is sitting within the emergency department, then you can start to do unstable patients, which we do in our department. So we do unstable patients quite commonly, is what I would say. Before, it was never imagined to do an unstable patient, that we'd have to go straight to the OR. But nowadays, because of the speed of acquisition, in a matter of sub-seconds, you're able to acquire all these images. It affords you this time, this luxury of being able to do these unstable patients in the setting of trauma. Usually it is a stable patient that is done in the trauma setting, but if you have access to a CT scanner in that vital time, then that affords you the luxury to be able to do a CT before the patient is transported to the operating theater.
Incredible. The next question here is focused more on X-ray and having to do with being able to see a sharp interface. So the question is, how long should a patient be upright to see a sharp interface on X-ray? And this is by Sadat.
Yeah, it's a great question. Usually the thought and the teaching has been that a patient should be at least a couple of minutes in the upright position to allow air to freely percolate to the most non-dependent portion of the abdomen. I would say if you're doing an upright chest radiograph, that is a true statement. You should allow a patient to be in an upright position at least 2 minutes. Some people even talk about 5 minutes, but I would say 2 minutes is enough time. If you're doing the left lateral decubitus radiograph, meaning your left side is down, your right side is up, so meaning you're lying on your left side, that is a more sensitive technique than even the upright chest radiograph, and that can be done within the matter of 30 to 45 seconds. By the time you position the patient, you get set up for the X-ray, that's enough time to allow air to be seen overriding the surface of the liver. But if you're doing an upright chest radiograph, an upright abdomen, then you should allow at least 1 to 2 minutes of time to allow enough time for the air to percolate to the most non-dependent portions of the abdomen. Of course, in a CAT scan, there is no time. A CAT scan is the CAT scan can see the air immediately that is perforated and free within the abdomen.
That follows nicely into the next question here, which is an interest in identifying upright versus supine radiographs. So the question is it possible to differentiate between upright and supine radiographs without any free air present?
Yeah, definitely. So the way you identify them is you look for the airflow levels. And what I would say is all of us have a gastric airflow level. So meaning in the upright position, if you look in the left upper quadrant, you should be able to see air rise to the top, where you see a little bit of air within the fundic portion of the stomach, and then you'll see a sharp interface with the fluid and the gastric contents layering within the body of the stomach itself. So that should give you a clue that you're dealing with an upright radiograph. The other key feature that you should look for is most technologists will put a marker either in the left or the right aspect of the radiograph, and they'll use an arrow that points upright. So you'll see an arrow on the actual marker with the initials of the technologist. And I'll go more about that technique when I do the chest radiograph in this series. We'll talk more about in the chest radiograph, more about technique, how to identify these markers. But usually you can identify 2 ways. One, look for the airflow levels. The normal one being in the gastric fundic airflow level. That's a normal airflow level. That implies an upright radiograph. Or look for the marker that points upwards. There's an arrow that points upwards. That implies you're dealing with an upright radiograph.
Excellent. Okay, well, let's try for 1 or 2 more questions. We've got one right here from Mohammed Ezra. And the question is, in unstable trauma patients, if FAST is positive, do you proceed to the CT scan or send the patient to the OR?
Yeah, that's a great question from Isra. That's interesting. I think it all depends where you are. And at our institution, given our CAT scanner is next to the trauma bay, the surgeons, depending on their, comfort level, and also the comfort level of the imaging specialist, You could identify hemiperitoneum, which is the presence of free fluid. You could say, let's go straight to the OR. But another thought process is the surgeon has that feeling that if I have that luxury that I'm able to get a quick CAT scan of this patient, and from a clinical perspective, he's afforded that opportunity, a lot of surgeons will go on to a CAT scan. Again, the reason for that is, although they're going to go to the OR, I think every surgeon would like a roadmap of these critical injuries. And what I mean by that comment is the following. If an ultrasound is performed in the scenario that Isra just described, and you see a hemiperitoneum, what I would say is the following. Is that blood coming from the liver? Is it coming from the spleen? Is it coming from the aorta? Is it coming from the bowel? Do I also have a bowel perforation on top of an active bleed? Is it coming from a complex pelvic fracture that changes my whole management, that I need to call my interventional radiology team because they're going to have to utilize special catheters to catheterize the arteries where the blood is leaking, to be able to embolize those leaking arteries to stop that bleeding. And the reason why I say that, because once you get to that operating theater, and you start opening the abdomen and you've got to suck all the clot out and all the blood, it becomes very difficult, and you're wasting a lot of time in being able to then all of a sudden close the abdomen and say, oh my goodness, the blood maybe is coming from a complex pelvic fracture. The last thing I would say is also, you don't know what's happening within the brain of the patient if you haven't gotten a CAT scan of the brain, and all of a sudden you're dealing within the abdomen and the brain, you could have a crushing hematoma that I'll talk about in the third lecture series, crushing your brain, and you have no clue that's happening in that situation. What is called an epidural hematoma, the silent killer, and that could cause some undue and unnecessary scenarios in the operating theater. So it's a very, what I say there is, that's why medicine, the beauty of medicine, it's not black and white. It's a different shades of gray is what I would say to everyone today on the call, on the phone. That's why you need that consultation between a radiologist and a trauma surgeon, and making those critical decisions in a matter of seconds of what to do. But that comes with experience, that comes of being involved in those clinical scenarios and making those life-saving decisions in a matter of seconds.
The value of bringing those multiple specialties together can't be
totally
understated.
And that's why it's a team-based approach. But I agree with Isra. Usually you'll want to go to the OR. But what I would say, if you have that opportunity, and that opportunity is afforded to do a very quick CAT scan in a matter of seconds, and you have the appropriate expertise, a lot of surgeons will ask for that CAT scan.
Excellent. Dr. Nicolaou, is one more question okay?
Yeah, go ahead. Yeah, totally.
Incredible. And I'd just like to say to all the participants, if you have any other questions, that there are going to be other lectures by Dr. Nicolaou in this series, and you can save any kind of burning questions for those series as well. So I'm going to pose this question by Bahina. So Bahina's asking if you could add a little more guide her towards the management of penetrating trauma to the kidney, such as before the case mentioned before. If there's any kind of additional, like how the decision making went towards managing.
Yeah, decision making. It's a great question. I mean, just for time, I had to simplify things. But the management of a kidney lesion is not straightforward, is what I would say. So, two different scenarios. One, the kidney is taken out. One is embolized. And I'll give you the third scenario, even the most common scenario, is nothing is done to a kidney lesion, kidney laceration. So the reason why the kidney was taken out, so this is the way it's done with kidney lesions and kidney management in trauma. You have to understand the decision in trauma is not isolated to one particular organ. So the initial decision in that first scenario that I showed was, do we go in and do we remove the kidney? The reason why the kidney was actually removed was not because it was actively bleeding. It was because of the other associated injuries that were more critical in saving the patient's life. And the injury that was more critical was the perforation of the bowel itself. So once you have a perforated bowel, you must act in a surgical fashion and go in and repair that leak, because the leakage of those contents will cause sepsis and cardiovascular collapse in that patient in a very quick fashion. If, for example, in that first scenario, there was no bowel perforation, the decision might have been made not to operate because of the complexity of the big hematoma, of the complexity of the operation, was to leave the patient alone, try to embolize that bleed, or just tamponade that bleed and allow that patient to, from a conservative fashion, stop the bleeding and give them blood units and give them fresh frozen plasma and stop the bleeding in of itself. The reason why they went to the OR was not based on the kidney injury, it was based on the bowel injury. But once they were in the OR, then the proper decision was made, why don't we remove the kidney since we're here anyway in that particular scenario. Now, the second scenario was, should they have done anything? And the reason why they proceeded to go to the interventional radiological unit to do a minimal invasive procedure by introducing catheters through the groin and then specialized catheters with embolization of the kidney was because the patient was bleeding extremely fast, as the CT scan showed, and also the patient was extremely unstable, is what I would say to everyone. So at that moment in time is, you don't want to remove the kidney because you want to save the kidney for the patient. So you go selectively embolizing the small arteries of the kidney. You selectively embolize with specialized coils. So you only embolize or cause infarction or ischemia to a very small portion of the kidney that allows you to save the remainder of the kidney by using that minimal invasive procedure that I talked about. The third scenario is that you have a traumatic injury to the kidney, the patient is stable, there's no other injuries, you manage that patient conservatively. So that is the process that goes into the management of kidney lesions, both blunt and penetrating trauma.
Incredible. Thank you so much for going into more detail for that, Dr. Nicolaou. And I think with that, we will wrap up our first webinar in the CyberPatient Expert Series. So I'd just like to say thank you so much, Dr. Nicolaou, for giving this excellent webinar. I really enjoyed it. Based on
my
the
pleasure.
Discussion and the questions, I think that the participants really enjoyed it. Thank you so much for attending, everyone. And
thank you, everyone.
Stay tuned for the next webinar. I think we'll August 20th is the next webinar for Dr. Nicolaou, and we
can't wait to be here.
We will confirm. Excellent.
We'll see everyone here. It'll even be better than this one.
That's incredible. Thank you so much again.
Thank you, everyone. Thank you, everyone.
Take care, everyone.
Bye-bye.